My topic, which is on nomenclature-related controversies. A good established classification and nomenclature system is essential to understand the disease with respect to its pathogenesis and chalk out a strategy for treatment. All of us know that primary angle closure disease is not a single entity, but rather it has varied clinical presentations about which Dr. Manju will be enlightening you in this session. And there do exist some confusions in gonioscopy and mechanisms of primary angle closure glaucoma. So encompassing all this into an established nomenclature is what is lacking in the system now. There are various ways of classification of primary angle closure glaucoma. These are all depicted on the slide. But what we need to understand is that we still need to have a comprehensive, well-accepted system on primary angle for clinical as well as research purposes. Coming to the clinical classification, which is based on the onset and timing of intraocular pressure rise, it is classified into acute and chronic. And the acute, based on the signs and symptoms, can be classified into preclinical with the prodromal, acute attack, which could be presenting as mild variety, or an acute sudden attack, and both of it can have preceding intermittent stage, and if not interfered with medically or self-aborts, or if it doesn't abort by self, it goes into the next stage, that's the chronic stage. Unlike the primary open angle glaucoma, where you have a triad of raised intraocular pressure, cup disc, and field defects, PACG does not require glaucomatous optic neuropathy damage in its definition. An angle is essentially normal. In chronic PACG, the peripheral anterior synechiae is almost always present. But one should understand again that the fallacy is that a subset of chronic angle closure can exist without peripheral anterior synechiae. And similarly, in acute angle closure glaucoma also, you can have cases with PAS. So again, there are a lot of terminologies, some where you have ocular hypertension with narrow angles and angle closures with previous angle closure attack. You don't know where to put them in the terminologies. Gonioscopy is very important for the diagnosis of angle closure glaucoma. And again, there are confounders in the grading system because Schaffer looks into the angle width and grades it from 10, 20, 30, 40, 45 degrees. And the Shees classifies based on the extent of the anatomical landmark seen. So all of them are concentrating on one aspect, and actually the spectrum is so complex that it is difficult to assess and define the glaucoma status with just one characteristic alone. So Spate looks into the angle width as well as looks into the plane of the peripheral iris configuration and looks into the level at which the root of iris inserts. So it's probably better. So thereby we classify into open or closed angles, occludable angles, and in the occludable angles whether they have potential for closure, which is revealed by either indentation or manipulative gonioscopy. The epidemiological classification, put forward by the International Society for Geographical and Epidemiological Ophthalmology, is actually very popular, and it categorizes into three groups: the primary angle closure suspect, wherein you have a normal disc and field, but occludable angles, while the primary angle closure has peripheral anterior synechiae, and primary angle closure glaucoma has both disc and correlating with field defects. Here again, the issues are, what is the definition of occludability? If you take more than 270 degrees of the posterior pigmented trabecular meshwork not seen, it's a very stringent criteria, and you miss 50% of those who have either PAS or GON. And if you take 180 degrees not seen, then again, though the threshold is very liberal, here again you may miss those with focal PAS or minimal appositional closure. Then the diagnostic criteria for GON in the ISGEO classification, again, it looks into the 97.5 percentile of normal population, which means a CDR of 0.7. So many in this definition will not be classified into PACG, even if they are glaucomatous. Look into this case scenario when you have diagnosis of a primary angle closure, that is no GON and elevated IOP. When you have elevated IOP, that indicates trabecular meshwork obstruction. And the limitation of this classification is it doesn't take into account the grade of trabecular damage or optic nerve head damage, or does not address ocular hypertension. So this subset requires a more closer follow-up because of the high risk of conversion to PACG. Next again, you can have narrow angles without PAS, and that means they have raised IOP, they have GON, But the mechanism, it has components of both open angle and closed angle, and that belongs to the combined mechanism group, which again is not reflected in this classification. So if you combine the clinical stages with the ISGO classification, if you look into the third row, you encompasses PAC with the ocular hypertensives. It is forms a separate category on its own. Coming to the mechanisms which look into the mechanism behind primary angle closure glaucoma, there I would like to say is that whether it is feasible to combine the mechanism also into the classification, clinically combine the two, it is to be thought of. But you have to, this particular classification actually, if you see any of the factors pertaining to the lens or plateau iris or ciliary block or aqueous misdirection or appositional synechial closures looking at the level of trabecular meshwork block, it is better to define it and classify it as pupillary block glaucoma, plateau iris syndrome, malignant glaucoma, creeping angle closure or multi-mechanism, because by this you explain the 58% patients who after laser iridotomy do again have recurrent acute attacks. Some of the case scenarios in daily practice wherein, which highlight some of the controversies is, all of us see patients with raised IOP and occludable angles and synechial closure and a seemingly normal disc. According to the ISGO protocol, you would call it as a PAC. But if you investigate and you see that the individual has OCT clock hour thinning, as well as a normal field, the diagnosis shifts and gets reframed to an early stage of PACG. So to diagnose PACG with the requirement of glaucomatous optic neuropathy alone is controversial. Coming to the second scenario where you can have acute angle closure attack, which is a straightforward diagnosis because all you want to have is this very sudden rise in IOP, but you can have instances when the patient may be having an intermittent closure and goes into an acute attack, or you can have a chronic angle closure patient who has a supervening acute attack. Where do you put these groups of patients? You may have an angle closure glaucoma suspect patient with a previous attack as reflected by this glaucom flecken. So these are the lacunae in the existing system. Coming to the third scenario, when you have a severe acute attack, you can have a disc edema. So not only GON matters, even other vascular factors need to be looked into, and that is not there in the definition of the ISGO system. So this OCTA is a sensitive tool which looks into the peripapillary vessel density. As you can see on the left-hand side, the figure A shows normal. In comparison, the angle closure post 1 month post-acute episode, look at the reduced peripapillary vessel density and the flow index as well is to reduce. While in the POAG on the right-hand side, you can see a focal loss here of the peripapillary vessel density. So these are all